Hello, everyone, and welcome to this FIP digital event. Good morning, good afternoon, and good evening to you wherever you're joining us from. Welcome to those joining us live and to those listening to us after this event. I'm very pleased to welcome you to today's event, Gender Equity in the Health Workforce, Accelerating Progress. We're hosting this webinar in honor of International Women's Day to celebrate the achievements of women all around the world. Today also serves as a call to action for accelerating gender equity. I'd like to take this opportunity to wish all women and men, particularly our esteemed panelists joining us today, a happy International Women's Day. My name is Noor Al-Tahla. I'm FIP Equity and Humanitarian Program Manager, and I'm very pleased to be hosting this event today together with my colleagues, Aysu Selçuk, who is the FIP Policy, Practice and Compliance Manager and who's based in Turkey, as well as Hanadi Al-Alemi, who is FIP Equity, Humanitarian and Sustainability Projects Coordinator, who is based in Saudi Arabia. Thank you very much, Aysu and Hanadi. Before we begin, I'd like to share some housekeeping announcements from FIP. So firstly, this webinar is being recorded and live streamed on YouTube. The recording will be available on our website, events.fip.org, as soon as this event ends. You may, of course, ask questions using the Q&A box provided, and you're welcome to provide any feedback to us at webinars@fip.org. And lastly, if you'd like to become a member of FIP and learn more about our work, please visit the website on the screen, fip.org/membership_registration. The agenda you see on screen is what we're doing today at this digital event. So we'll start with welcomes and introductions by our FIP team, including an overview of our Equity and Equality program, Equity RX, followed by a quote from Parisa Aslani, who's the FIP Vice President and FIPWise Executive Sponsor in Australia. We will be listening to a presentation of key findings from the Women in Global Health report from Rupa Dutt, and this is followed by a panel discussion on the opportunities and challenges faced by women in the healthcare sector with a specific focus on pharmacy and on the gaps in gender equity. And we will end this webinar with a Q&A session and some reflections and conclusions from our CEO, Catherine Duggan. The aims and objectives of this event are to showcase key findings from FIP reports on global workforce trends, as well as some key findings from the Women in Global Health report on the pandemic's impact on women in the workforce. We also aim to explore how the pandemic has affected women in the healthcare sector, particularly in the pharmaceutical workforce. We also aim to explore challenges, opportunities, and strategies to address gender inequities exacerbated by the pandemic and to promote equality in the workforce. And finally, we aim to set the foundation for a call to action towards fostering gender equity in the workforce and towards investing in women to accelerate progress. I'd like to introduce our esteemed panelists, these remarkable women who are here from different parts of the world to share their knowledge and expertise with us. It's an honor to have an international panel on International Women's Day. Firstly, I'd like to introduce our FIP CEO, Catherine Duggan, who's with us today. Thank you so much, Catherine. And joining us from the United States, Rupa Dutt, who is the Executive Director of Women in Global Health. From the UK, Bahija Raimi Abraham, our FIPWise Chair and an Associate Professor at King's College London. From the US, Vibhuti Arya, who's FIP Development Goal 10 Lead and Professor at St. John's University. Last but not least, from Australia, Parisa Aslani, who's FIP Vice President, FIPWise Executive Sponsor, and Professor at the University of Sydney. Parisa is not joining us live, but has kindly sent us a quote, which we will share with you later on. And while these very brief introductions may not fully capture these remarkable achievements, we'll have their detailed biographies available in the chat. So please join me in welcoming these inspiring individuals whose knowledge and expertise is invaluable to our work and to this event. Thank you all for joining us today. So diving into FIP's work, I'd like to first mention FIP's 21 development goals, which reiterate FIP's commitment to bettering global health through pharmacy. And these goals, they're a key resource for transforming the pharmacy profession over the next decade, globally, regionally, and nationally. and they align with FIP's mission to support global health by enabling the advancement of pharmaceutical practice, pharmaceutical sciences, and education, and they're set to transform pharmacy in alignment with wider global imperatives underpinning the UN Sustainable Development Goals. Of particular importance to today's event is FIP's Development Goal 10, the Equity and Equality Goal, which calls out for clear strategies to address inequalities in the pharmaceutical workforce, to widen access and equity of pharmaceutical care services and access, as well as equity in global capacity in pharmaceutical sciences development. This goal is composed of three main elements that you see on screen: the workforce and education element, the practice element, and the science element, all of which call out for clear strategies to address inequities in each of these areas. FIP's Equity RX program is its equity and equality program, and it supports the progress and implementation of Development Goal 10 at a local, regional, and national level beyond gender and diversity balances, extending to equity and access to care and all that this encompasses. This program operates under the motto, pharmacy leaving no one behind. It's a large program encompassing many unique areas of work, all of which come together to support equity and equality for all, despite the following social, demographic, and health identifiers that you see on screen and their intersectionality. These identifiers include age, disease and comorbidities, gender, literacy and access to education, mental and physical ability, race and ethnicity, religious beliefs, sexual orientation, and socioeconomic status and class. Currently, Equity RX has 6 main areas of work, which include FIPWISE, or FIP Women in Science and Education, FIP's Gender Equity Program, a program area on gender pay gap, one on maternal health, one on health literacy, and one on vaccine equity. You may, of course, find out more about these program areas and about our program by visiting our website, equityrx.fip.org. I'd like to now hand over to my colleague, Aisu, to tell us more about the program. And thank you once again for joining us, and happy International Women's Day.
Thank you, Noor. Hello, everyone. Happy International Women's Day. Today, I would like to share the overall FIP outputs for gender equity. Next slide, please. Okay, FIP has published several reports about the issue, and you may see them in the slides, and all reports are also available at FIP Library. I am going to soon share the relevant links for these reports. But for example, Pharmacists Supporting Women and Responsible Use of Medicines report highlights the contribution to Society of Women as informal caregivers to support female informal caregivers and bring the world closer to health for all. And the role of pharmacists in promoting female intimate wellness report includes a comprehensive understanding of the role of pharmacists in promoting female intimate wellness and to obtain information about different strategies and issues pharmacists face in this area. So in the next slide, FIP also published a toolkit for enabling positive practice environments for women in science and education. In the toolkit, 5 factors are defined to raise awareness and provide possible solutions for individuals, employers, and institutions. This work also published as a journal article. In the next slide, according to 2023 FIP Global Workforce Surveillance Project Report, women constitutes most of the global pharmaceutical workforce. And if you see the second figure from the report, it also predicted that the average female proportion of the total global pharmacy workforce will exceed by 2030 around 72%. Indicating an estimation of a high representation of women in the pharmacy profession at the global level in the future. Therefore, if we don't act today, the gender issue will be bigger in the pharmacy workforce. In the next slide, I would like to share some of FIP's great achievements on addressing gender gap over the years. In 2016, FIP Bureau established a working group on women and responsible use of medicines to gather evidence on how pharmacists have the potential to contribute as agents of women's empowerment through supporting and promoting their education and providing them with information they need to ensure medicines are used responsibly. In 2018, FIP Equity RX became the overarching label and unifying theme for FIP's initiatives and work on gender and diversity. These initiatives focused on empowering women both within and beyond the workforce through promoting equity. In 2020, FIP launched the FIPWISE initiative to help achieve gender equity for women in pharmaceutical sciences and pharmacy education and also to empower them. In 2021, Equity Pakistan, the Gender Equity Hub for pharmaceutical workforce in Pakistan, was launched in Islamabad, Pakistan. And the hub is a collaboration between UCL School of Pharmacy and Hamdard Institute of Pharmaceutical Science, Islamabad. And finally, I would like to share FIP's recent work on the gender gap in the next slide. And this was the Accelerating Towards 2030 Workforce Transformation for Better Health Symposium, which held on during the 81st FIP World Congress of Pharmacy and Pharmaceutical Sciences last year in Brisbane, Australia. So during the symposium, it is marked a significant opportunity to review and refresh all global pharmacy workforce transformation objectives. And the symposium participants developed a consensus on a call to action driven by expert insights and current evidence from the FIP Global Pharmaceutical Observatory and the FIP Hub. In the call to action, Action 6 is to encourage equity, diversity, and inclusiveness within the pharmaceutical workforce. And FIP is committed to developing an action plan and specific projects that advance this important goal. So that's all I want to share now. I am handing over to my colleague Hanadi. Thank you.
Hello, everyone. This is Hanadi. I am delighted to be here today to celebrate International Women's Day with all of you. It's my great honor to present on behalf of Professor Parisa Aslani, the Vice President of FIP and the Executive Sponsor of FIPWISE. I will share now her quote on equity and equality for women in science and education. So, according to the evidence collated in FIP resources, the number of women in pharmacy has steadily increased over the period of 2009 to 2016. The average proportion of females in the total global pharmacy workforce will exceed 72% by 2030, indicating a potentially high representation of women in the pharmacy profession at the global level in the future. However, women health workers, despite their significant contributions to the healthcare system and to patients, face low pay, inadequate employment protection, and increased unpaid care work. According to the UN, gender equity is the greatest human right, and therefore investment in women is essential and beneficial at so many levels. There is a need for urgent actions to encourage equity, diversity, and inclusiveness within the pharmaceutical workforce as also in all health sectors. We can encourage the development and evaluation of services that aim to empower women in their roles. We can advocate for governments to improve health outcomes by ensuring a stable financial commitment for training and empowerment projects targeting women in the health sector in collaboration with healthcare professionals and pharmacist associations. We can also advocate for key stakeholders in creating and implementing different strategies for women with a wide range of activities to provide equal payment, protection, investment, and empowerment. Importantly, we can advocate for everyone to treat each other equitably, as only together can we make huge advances in health and patient outcome. So thank you all for joining us, and again, happy International Women's Day, and over to you, Aisu.
Okay, thank you, Hanadi. And now I would like to introduce our speaker, Dr. Ropa Dahat. Thank you, Ropa, for being us today, and the floor is yours. Thank you.
Great, thank you. Wonderful to be here and just be among such great company. And especially a special shout out to Catherine Duggan, just for her friendship and support, as women leaders must support each other. So it's really such a wonderful honor to be here on International Women's Day. I'm just going to kindly ask the team if it's possible to pull up the slides as I talk about this very important topic on the great resignation of why women health workers are leaving the health sector. Okay, great. Yes, I can go ahead. I can see the slides. Thank you. Okay, so first to kick us off, I want to share a bit about particularly, excuse me one second, I'm just having a technical issue here. Okay, great. Thank you. Share a bit about women in global health. If you're not familiar, we've been partners with FIP for a very long time, but Women in Global Health, we were launched in 2015. We now have over 57 national chapters in 50 plus countries with a very strong presence in low middle income countries. Women in Global Health is continuing to expand our network of national chapters, and we primarily ensure that we are doing advocacy and using evidence to drive for advocacy through policy research, and bring the perspectives of our chapters into the work that we do. We're building a global cadre of influential women leaders in health working together to influence national and global health policy on gender equality, women's leadership, and safe and decent work for women health workers, and including gender responsive health systems. We take an intersectional approach to gender equality. Women are not a homogenous group, and women belong especially to a range of marginalized groups, including based on race, class, caste, age, ableism, ethnicity, sexual orientation, identity. They face greater barriers than other groups of women in accessing health services and decent work. And our goal is to reach those women who are traditionally left out of the global dialogue, to address power and privilege in all of its forms, to drive health equity and gender justice at all levels. Next slide, please. So in the front line, women have led the response in the health sector. They hold 70% of the health worker jobs and over 90% of nursing and midwifery roles. Women working in health systems, from midwives to pharmacists, have been disproportionately at higher risk of COVID-19 infection, as their work involves close contact with patients. Moreover, when they were able to access personal protective equipment, we have found that personal protective equipment was not designed for female bodies, but really the default male bias exists in PPE. We know that with sex disaggregated data on infection of health workers is scarce, but evidence suggests that women with long COVID outnumber men by as many as 4 to 1. Now I'm going to focus on the impacts of this in greater detail. If we can go to the next slide. Yeah. Great, next slide. Great, and next slide. Great. So I'm going to be focusing a bit more on what are we seeing exactly as women as the social shock absorbers in emergencies during COVID-19. Particularly, women are the social shock absorbers in emergencies and crisis during the pandemic. We've heard it, we've seen it, we've experienced it. Not only were women asked to do more in the health and care setting, but they were also asked to do more in their household and more in their communities. But when you look at particularly their engagement in the health sector, women were marginalized in decision-making. They were represented in leadership, although they had the expertise, especially in the COVID response. They were at the bedside, in their and patient-facing roles. But when you take a look at COVID-19 decision-making at the highest levels, we mapped out 115 task forces around the world, and 85% of them had majority male membership, and less than 5% had gender parity. We also know that high risk of infection was a major issue and driver. So PPE is designed for men, ill-fitting PPE has led to at least 7,000 women health workers having deaths from March to September 2020. As you can see, that's a very short period, so we know that number is much more. We know that women are working in unsafe working environments. 4 in 10 women felt more unsafe in public spaces than before, particularly with violence increasing, but we also know there is sexual harassment and sexual exploitation taking place. There's been a double burden of care, and I often say it's actually a triple burden of care. We know that on top of long shifts and increased patient loads, at home, women contributed at least 5 hours more to childcare. And as mentioned, they were also expected to take care of their communities in beyond what was the norm before. Gender-based violence increased significantly in some of the surveys, reporting at least 45% of women reported they or women had experienced gender-based violence during the pandemic. We know financial hardship is very prevalent. Women health workers on average earn 24% less than male counterparts. And this is the gender pay gap estimate from the WHO and ILO. And then over 6 million women are currently unpaid or grossly underpaid. And this is work that Women in Global Health has highlighted in our Pay Women report if you want to learn more. There's been a disruption of essential health services. So during the early months of the pandemic, as health systems shifted to essential health services, surveys had showed that some WHO survey had showed that in some places, even up to 60% of health systems had shut down or made access to maternal health, neonatal services, family planning services, shut 60% of those down. So we know that, sexual and reproductive health services were often deprioritized, and it has impacted at least 12 million women, leading to 2.7 million unattended pregnancies. Mental stress, increased PTSD, risk of depression and suicide. 78% nurses in West African countries report moderate stress, and 10% reported severe stress. We have all heard about the stories of very tragic stories of women health workers, doctors, nurses, midwives, community health workers that really not only was it the increased stress, but it led to suicide in cases because of how just plain awful the circumstances were and how lack of support women health workers were facing, and additionally their inability to change the health systems they were working in. And all of these stressors on top of existing gender inequities have caused a widespread burnout amongst women health workers. So we are talking about at Women in Global Health that this was already a stress system, and then the pandemic happened, which really further exacerbated and overwhelmed and took this house of cards, and basically that house of cards is collapsing because women health workers were expected to take even more on, and they're just not able to. And this is, leading to a great resignation of women health workers, particularly in high income countries. In the UK, 1 in 9 nurses have left. And as surveys in the United States, one just came out recently focusing on physicians in academic centers, and 30% of physicians are reporting in academic centers that they're planning to leave the workplace, which is very high percentage in comparison to pre-pandemic, where those surveys would show about a 10%. We know all of them won't leave, but just showing that 30% of the workforce is thinking about leaving. Imagine what that means for the health worker, the health system, but also patient care and communities. This exodus of great health worker resignation, especially in high-income countries, is leading to a great migration of women health workers from countries with vulnerable health systems. So as the high resource countries are facing greater shortages, we are seeing that even more than before, a greater migration taking place. And this is destabilizing systems that already struggle to hold on to health workers. So, this is what is the Great Resignation, a link to the Great Migration, causing a collapse of health systems worldwide. Next slide, please. So the burnout and stress, the COVID-19 effect, global snapshot. Here's a couple of highlights. What you'll notice is that whether you're in the United States or China or Spain or Australia, and there's hundreds of surveys. At one point, there were health workers in 100 countries striking, based on the conditions they were seeing in COVID-19. But we are seeing that health workers, 90% are reporting experiencing stress, 76% are reporting exhaustion and burnout. In China, 60% of nurses exhaustion, 90% anxiety. Spain, 80% anxiety and burnout. Australia, 61% report burnout and 28% report depression. And really, to put a face behind these numbers, it means that every interaction that a patient or a member of the community has with the health system will at least have one encounter where the person that is responsible for taking care of them is actually mentally stressed and at capacity. So this is happening universally in every part of the world. Next slide, please. We also know that personal protective PPE was designed in a manner not fit for women. During the pandemic, Women in Global Health participated and led the design of a survey. And we found that in the North American setting, that it was actually a male prototype from the 1960s that was being used to design all of the personal protective equipment. So the male default bias very present when it comes to personal protective equipment in general, but especially in health and medicine. And the examples of what women experience, many times women said they fainted because it was too hot and wearing their PPE. As women were menstruating, the PPE was designed in a way which was difficult to get in and out to deal with menstruation health and hygiene. Many times workplaces did not even provide access to menstrual products, even though the shifts were expected to be sometimes a week long, even upwards to several weeks. And then in many countries, they did not know the size of their health workers. And we already know they struggle to disaggregate data by sex. So they just assumed if we purchase extra large or extra large personal protective equipment, that it would fit everybody. So there are, numerous examples of women using tape and other methods to try to get on the gowns and gloves. And we know if PPE is not fit for size, it just is the ill-fitting will result in more infections. And all of that, has resulted in women health workers having a lot more infections, having long COVID, and then personally feeling not taken care of and not protected. Next slide, please. Violence and sexual exploitation, abuse and harassment. Here are some quotes from two different health workers. Here's from Spain. As far as I know, nobody has told him anything. When I tried to raise the issue with some colleagues, they laughed and said they'd experienced the same, but poor him, he can't resist. Another quote is from a physician in Ethiopia. I was afraid nobody would believe me since he is well loved by his colleagues and appreciated for his hard work by his supervisor, so I kept quiet. Even if I report it, it will lead to drama with no concrete outcome, so why bother? I kept silent for 3 months and waited it out. It was the most frustrating experience of my life. And these two quotes both really highlight that when women experience violence, and especially sexual exploitation, abuse, and harassment, there's a complete denial in the system and an inability to even accept the experiences and the violations that are taking place. And so the women face retaliation, they face denial from the health system that this is taking place. There's the bystander effect, excusing men for their bad behavior instead of really holding them accountable. And for these reasons, many women don't even enter the workplace in the health sector, or they choose different professions. They may not go into specializations where there is night duty, or specialization which may require being in close proximity to men, such as surgery. And instead of taking health systems and designing them for everybody, health systems continue to be designed by men for men to keep men safe and protected. And we're talking about really transforming this, because it has worsened in the pandemic, and it has worsened after, as we know that the growing polarization and frustrations in societies and communities and growing mistrust in health systems means that women health workers are going to be facing and are facing the brunt of that frustration. Next slide, please. Lack of fair pay and support during the pandemic. So there are numerous examples of, even though the workload increased and care responsibilities increased, as these are the same women health workers that would have care responsibilities, whether it was children at home or caring for other members of the family or community or elderly parents. They were also expected to have much longer shifts in the hospital. And despite this, policies were not really tailored to take into account the reality of women's lives. Often the working hours were inflexible, and they were given competing demands of both home and work responsibilities. In Japan, 73% of nurses said they had unfair treatment and forced to change shifts or take unpaid leave. Brazil, women doctors describe rigid work schedule that conflicted with their childcare responsibilities. In Ireland, nurses were forced to choose between caring for their children and reporting to work. In Canada, midwives needed to take time off from work, considered quitting, or left their jobs because the absence of this crucial support. And this is really critical for recognizing and approaching the gender equity solutions in the health workforce, is recognizing the care roles that women do have and how they heighten during periods of crisis, such as the pandemic. Next slide, please. So this is all accumulation of all this is what's led to us really, at Women in Global Health, spotlighting the issue of the Great Resignation, why women health workers are leaving. We encourage you to check out our report where we go in greater detail. This is just a snapshot analysis that I've provided. We are looking at this very much as a dynamic, evolving issue. So we will continue to be covering the Great Resignation as well as the Great Migration that is linked to what's taking place, and really hoping to work with all of you to find the solutions of how is the community in locally where you practice as a pharmacist, to regional and globally solutions that are taking place to address both the resignation and migration. Next slide, please. And so, to unpack the specific data of how many are leaving in the UK, the estimate is that at least 170,000 staff have resigned from the National Health Service. In the United States, 100,000 have left since the start of the pandemic, and 800,000 more, which is about 1 in 5, plan to leave by 2027. Next slide. And then the Great Migration, which I've already alluded to, the WHO is tracking which countries have critical shortages of health workers and what they have found. And the document that they released where they're tracking this, the WHO Global Code of Practice, went from having 50 countries on it to 55 countries, with more than 80% of those countries in Africa are showing that there's a greater migration of health workers, which is now resulting in even more countries having shortages. And so now there's 55 countries on the support and safeguard list. 1 in 8 nurses are practicing in a country they were not born or trained in. Next slide, please. So our key messages from this report, and you're welcome and encouraged to check this out, is that COVID-19 has deepened existing gender inequities, especially among women and health workers. Women health workers are burnt out and resigning in significant numbers. The resignation of significant numbers of trained women health workers in high-income countries is driving a great migration from low-income countries, further weakening the vulnerable health systems. 3, a significant global shortage of health workers emphasizes the urgency of implementing national health workforce plans for retention of health workers and taking measures to aid re-entry of health workers who have left. Fourth, the global efforts to prevent vulnerable countries from losing their health workers may falter if high-income nations create strong incentives for health workers from low-income countries to migrate. We are calling for the 2010 WHO Code of Practice of International Recruitment of Health Personnel to be adhered to. Next slide, please. Finally, as we come to a wrap, at Women in Global Health, together with our partners, we are calling for women health workers needing a new social contract that is based on equality. This requires women to have equality in decision making based on gender transformative leadership. Second, to have safe and decent work with fair pay, fit for purpose personal protective equipment, and workplaces free from all forms of harassment. Next slide, please. Final word, the pandemic has impacted everyone, but it has impacted women and men in the health sector differently because of the different unequal positions they hold in health. The health worker shortage is estimated to be 15 million and rising. All health leaders must adopt a gender transformative leadership approach, intentionally building on equity, using an intersectionality lens. Addressing the Great Resignation will mean addressing the root causes which lie in the gender inequities women face within the health workforce. We know that many health workers, particularly women health workers, were celebrated through getting applause and candles lit, other forms of recognition. But what women healthcare workers want is a new social contract. They want change. They want action. They want increased investment and support. So show us you care. We cared for you is much more than a round of applause. So turn that applause into action. Thank you. And then I think we're on the last slide.
Thank you, Ropa, for your kind presentation. Now I would like to introduce FIP Chair, FIP CEO, Dr. Catherine Duggan, for her chairing the panel discussion. Thank you, Catherine. You are muted, Catherine.
Apologies, colleagues. I couldn't unmute there. I would welcome the panelists to open their cameras so that I can introduce them all. Rupa, we're delighted to have you here today, and thank you so much for that presentation. And I think Bahija and Vibhuti, we three now have got work to do to join forces between FIPWISE, which is our Women in Science and Education, and our development goal on equity and equality, which is inclusive of women in science and education, but also much wider. And I think one of the commitments we make, Rupa, at FIP is to take the report you've presented, both reports, and to map and track where we might be in our profession. So that's one commitment I make even before we start the discussions. And I think listening to Rupa, and Vibhuti and Bahija will agree with me, I'm sure, that if we didn't have Women in Global Health since 2015, the pandemic shows us why it would need to be invented. As ever, Rupa, you are ahead of the game, and it's up to us to amplify your voice for our profession. I think it's great. Before we get going, colleagues, I find these days very humbling, and it's very appropriate for me to just say a couple of words about while we understand there are inequities and inequalities, we all have got the position of privilege because we are professionals. We are articulate women in positions that we can lean into. I'm always in awe of colleagues who have children and families. I have a family that I do caring of as well. But, you know, I just think that we should take better care to understand each other's worlds and use our position. I'm the first CEO of FIP, and many of you will know that because I say that very many times. I think in that position of privilege, I must never forget that, and I need to be a good role model for my team. I thank the team here today, many of whom aren't particularly comfortable doing presentations, and I'm sure my panelists will agree they have done splendidly. And that's just a moment for me to say a big thank you, and to all of my team at FIP, the international women, but also the men in our team as well, and our profession. So that's enough from CD, so to speak. But Rupa, you have our commitment at hello. I've got some questions. And we've got about, let's say 15 minutes or so, because then we can do some rounding up at the end. I've got a question for us all at the very end. But I'm going to go round panelists and get each to take a question in turn. And if the other panelists have got any observations that they'd like to make, then they can do so in the chat. But that means, panelists, we get the biggest bang for our buck today with you on our screen. I'm really delighted to have you all here. So I'm going to start with Rupa. Rupa, you've shown us the stark facts, the facts that probably we run far too much to capacity anyway in our health systems, and women do far too much at capacity anyway in all of our lives. How many times are you doing 7 things at once, and then by the end of the day, you still have a to-do list that's overflowing? So when we see something like a pandemic, and that was a global experience, again, those in places of privilege suffered less badly than those in with less privilege. But also, I think this really shows that we do not have the resilience in our systems to really cope with crises, whether they are national crises, regional crises. So what would you say are the potential roles for governments, policymakers, and other health stakeholders to invest in women across the healthcare workforce? And Rupa, I know you're not a pharmacist yourself, so feel free to bring any of your learnings from the world of medicine alongside as well, because I think that's really invaluable for all of us. Rupa.
Great. Thank you, Catherine. And I must first acknowledge your commitment to share the evidence that Women in Global Health has put out there. And we consider the pharmacy community and FIP a really valuable partner in informing even the evidence we've gathered in those reports. So really appreciate that commitment. But to really, pick up on your question, how do we take, what we are seeing and get our governments to really respond and take action and be accountable to what they are supposed to be providing all workers, but especially health and care workers, is decent work. This is not, a new agenda. So the first thing that I would say to all health workers, pharmacists, physicians, nurses, midwives, those that don't get counted, which are community health workers, is to recognize your rights and to know that there are conventions out there that protect those rights. One is particularly the International Labor Organization has a decent work framework, which has been around for over 100 years. And more recently, they launched a convention called ILO 190, which is particularly looking at ending all forms of violence and harassment in both the informal and formal health sector. And guess what? They did identify the health sector as one of the highest sectors as far as violence takes place. And there's an opportunity to get governments to ratify this convention. And I'm delighted to hear there's been a lot of momentum in ratifying this convention from a diverse range of governments, from high income settings, low income settings, in Asia to the Americas. So, the first thing I would say is that, really look to your policymakers, your local policymakers. They may be members of parliament, to start endorsing global conventions and global ratification tools that are offered by ILO. At Women in Global Health, we have launched in 2021 with the government of France, the Gender Equal Health and Care Workforce Initiative. We continue to co-lead this with France. We launched this in 2021, really recognizing that, health systems cannot function without women, and that gender inequities must be addressed across the 4 pillars I've talked about in the presentation: leadership, pay, protection, and really supporting women health workers. And we're delighted to say that we have over 50 different organizational and government commitments. Nearly 20 governments have signed on to this, including multilaterals. And in addition to making that political commitment, many of them have gone on to then start the commitment and putting it into policy actions. So one of our pillars, which focuses particularly on violence and harassment, the one that is rarely discussed. Our government commitment from Ethiopia included doing a gender-based violence assessment of the health workforce. They've actually implemented that assessment, started collecting data, and are looking at that data now to design solutions. Another government, Liberia, already was committed to formalizing the community health workforce, but that was done from a gender-blind way. So jobs that were mainly, or I should say volunteer roles that were mainly occupied by women, when they became formal jobs, were then all of a sudden occupied by men. No surprise there. But the government of Liberia has been working on policies now to increase and formalize and recognize women in community health worker roles and to balance that gender inequity. So those are examples of how the unpaid work and doing it from a gender point of view. There are many examples of governments also adopting gender parity quotas. Often this begins at the highest level when it's the head of state or the prime minister, the president, who says that their cabinet will have 50-50. What we've been doing is trying to get governments to make this part of their Ministry of Health, and to really encourage parliamentarians to adopt policies where they make this into quotas. But for us at Women in Global Health and the health system, it's every level of the health system, not just the highest level, that must have gender parity. So we have been calling for all women shortlists for leadership roles. We're saying for decades, and you could say centuries, there have been all male shortlists. So there's nothing wrong with having an all female shortlist for top roles to balance that equation, which is clearly unbalanced. And then finally, going back to a framework that all of you can use, especially to ensure that there is decent care work, is we're following the International Labor Organization 5R framework. If you're not familiar with it, we really encourage you to check it out. And also just to learn about ILO, they have a lot of amazing tools to have workers understand their rights and how to protect their rights. And the 5R framework is about recognizing, reducing, redistributing unpaid care work, rewarding care workers by generating more and better quality work, including pay, and promoting the representation of unpaid carers, care workers, and care recipients in social dialogue. So I hope I've given you a couple of tips, but there are many ways to engage your government and policymakers. They are obligated to uphold your rights as health workers.
So, Rupa, I think that provides us with a little bit of a narrative to get our teeth into, potentially at the end of this day, so that by the time we get to International Women's Day 2025, we've made progress at FIP with all of my dear colleagues here on the panel and wider. We'll come back to Rupa in a little while, but Vibhuti, I go to you next. And we know that we've got frameworks, we know we've got the facts on the table, but I think actually we also need to identify the challenges and the gaps that prevent some of this investment. And maybe it's as simple as us finding our voices and using the facts to compel, but what would be the challenges that you see, the challenges and gaps to invest in women in the workforce from your perspective, Vibhuti? And I don't mind if you draw on your own experiences or your own sector within the profession, and perhaps tell the rest of the audience, where you're working. But I also think more widely, you will have that perspective. Thank you.
Thank you. And thank you to our colleagues here. I'm honored to be part of the panel. Rupa, as you were talking, I'm taking furious notes because I think there's quite a bit of overlap, of course, across sectors. So I work in public health practice. I work with the New York City Health Department as part of my role as professor at St. John's University. I immigrated to the US from India. And one of the things that among a lot of immigrant refugee communities that we've seen as well, not just in the US, but also globally, having these conversations, pretty much everything, Rupa, that you were mentioning, one of the things that we're also noticing is The word that you kind of talked about, which I hone in on quite a bit, is accountability. I think the challenge really lies that we hear the words quite a bit. We hear a lot of talk and we hear a lot of things. And really being able to muster up the social political will to kind of move those words and commitment into action is, I think, a huge challenge that we face. The burnout, the stress, the moral injury, even if you will, where people are called to serve in a capacity and are not being taken care of. And then as a result of their sort of cup being empty, then serving others and potentially not making mistakes or not doing the best that they feel that they need to do also takes a toll on all of us, particularly in healthcare. And I think the systems where we don't have accountability kind of backfires, right? So we're hearing those quotes that were so powerful that you shared, Rupa, with us. One of the ways in which I think that we need to move the needle is really understanding how those systems of accountability exist, critically thinking through those processes. So we tell people that you should report things or that you need to talk about these things. But the fear of retaliation, a lot of times those systems don't actually yield an accountability. They don't even yield an acknowledgement. Many times for legal reasons or whatever other reasons, they're kind of hidden and not transparent. So as a result, something that could be happening on a collective level seems like it's happening in isolation. And when you seem like you're suffering trauma in isolation, it can be a very lonely space. It can be very hard to get out of there. Trauma we know is a mind-body disconnect. And so a lot of these things of burnout, stress, and moral injury add to that, right? So as we're juggling all these things, do I now want to write a report, relive that experience, to a system that really is not accountable to me, to a system that really is not going to yield any results? And so I think that we have to do better jobs critically thinking through the processes we have in place, challenging the assumptions that we're making, because we're assuming a lot of these things are going to actually result in something that doesn't. Really thinking through unintended consequences of what our ideas are and what those processes are. A lot of times people who are impacted, and I'm glad, Rupa, you brought up the other marginalized identity, that intersectionality does exist. And so in that matrix of privilege, some of us may have more than others, and some of us may have them different times throughout the day. Which room we enter, we may have some privilege. Another room we enter, we don't have that same privilege. And so I think that that has to be recognized, that a lot of those people, sometimes us, we're creating these policies and processes, are not actually the ones who this is impacting. And so how do we get the people who are impacted at the decision-making circle so that we're actually having those conversations in a much more wholesome and holistic way that actually then will move the needle to yield accountability? So I'll stop there, but that was a big download into a lot of systems changes and environmental kind of reform that we can really hold ourselves accountable for.
Well, I think, Vibhuti, when we respond to someone like Rupa, who has this amazing helicopter vision, but also the ability to go microscopic with data, you have to present it in the cobweb nature of intersectionality and interrelations. It means that I'm going to have to adapt my questions because you're all answering nearly all the questions. But I'm going to go Bahija now and thinking about right here, right now, you in your world, what are the challenges that women face in the pharmaceutical sector, whether that be in education or pharmaceutical sciences, particularly during the pandemic? But as we've emerged out of the pandemic, I don't feel we've lost any of those challenges. I feel like we're carrying them alongside everything else as well. But I'm interested in that. But then what I plan to do, colleagues, is I'm going to get Rupa to answer another question, you two to respond, and then we'll finish with a 30-second response, just so we hear from each of us. Bahija.
Thank you, Catherine. And also thank you both to Rupa and Vibhuti for your insight. And you've probably seen me nodding throughout everything you're saying. So I'm based in the UK. And again, when we're talking about different experiences, so my experience is very much UK related. But because with the work that I do, the conversations I have is very global. So there's some commonalities in different ways, and there's also some very different experiences that people face in different parts of the world. I feel that even though, Rupa, as I was listening to the data from the insights from the pandemic, I was realizing that I feel some of those things are still very much happening now. And when people say we're in this post-pandemic world, I'm not sure what's going on. I'm not sure if we're truly post-pandemic in all aspects. And I feel that there's been a push or a drive, and I'm just sharing my own sort of personal insights, that there's been a push and a drive to revert back to life before the pandemic. And all of a sudden now that things are a little bit different, it's like, okay, we're pre-pandemic behaviors. And I feel that we're losing the opportunity to implement what we've learned in terms of issues and challenges faced by women. We're losing that opportunity to implement and make a new change. Change is okay, change is what we need for progress. And so I would say that something that has come up a lot that I've identified is the safe working, creating safe spaces for women to have conversations, discussions, to report, to share. Vibhuti, I completely agreed with what you're saying, where somebody may have a certain experience in isolation, but not realizing that other people are having those experiences as well. And so as a result of those working in your silos, like if I say for myself as an academic, when you start in your academic journey, it's very lonely, right? You are building your research group by yourself. You're doing things by yourself. If you're working, I also am a pharmacist. So if you're working I have community and hospital pharmacy experience. But again, we're always working by ourselves. And that can result in many different experiences. That can result in microaggressions. And if we're taking intersectionality, my experience as a Black woman in academia is going to be very different from anybody else's experiences and vice versa. And I think the elements of intersectionality that contributes to our experience, plus the isolation that comes with being the only woman in a professional space. And Catherine, I really agree with what you're saying about our own privilege of being professional women and what that the experiences we will have versus if, let's say, for somebody else. But that isolation, the fact that even as a professional woman, and even trying to work up the professional ladder, getting into leadership roles, that trying my best, there are experiences I have, the things I have experienced, and I know people have shared with me that you'd be surprised about. Inappropriate comments that are being made, being sexualized. Meanwhile, you're not trying to or anything like that, and so therefore I feel that a big challenge, in order for us as women here today, other women that are working in different environments that may not be able to connect today, in order for us to even just do our job, let's not even talk about the advocacy side of things and the change elements of our job that we're trying to do. In order for us to just be able to do our job, get into work, do our job, and complete our task, we need to feel safe, right? And that's physically safe, emotionally safe, mentally safe. And I've had in the one of the podcast interviews, I talked about, do we have, and psychologically safe? Yes, thank you, Vibhuti. Psychologically safe as well. Things that I've been looking at is how can we have those formal and informal reporting or communication channels. The informal elements can be a little bit challenging because when it's informal, and if, let's say, so if I just talk about my department, we have something called confidential advisor. And this means that anybody can go and report through the confidential advisors issues that they've had, things that they've experienced. But then you also get people reporting to non-confidential advisors. So then you have this problem that if you don't have that title as the formal confidential advisor, what can you do with that? Catherine, please let me know if I've gone off topic. Sorry, because I could talk about this for a long period of time, but please just pull me back.
Bahija, I'm gonna suggest something. I feel ISU is in charge of this, but we have an interview series where I interview a couple of colleagues, and I feel like the conversation that we've started just here needs to be captured. And I think we would be doing our profession and our attendees a disservice if we didn't continue this. We're running really close to the hour now. So what I'm going to do as a legacy item for ourselves, I'm going to start with Rupa, go to Vibhuti, then Bahija, and then I'm going to finish with if we had one sentence to say to ourselves years ago, when we were early in our careers, obviously we're all young at heart, but when we were younger, or what message would you say to a young healthcare professional who looked very like you at this time, but say 10, 15, 20 years ago, longer for me, but Rupa, and a one sentence, Rupa, and then I promise you, I will round up with some commitments from FIP, because an hour is simply not enough. Rupa, Vibhuti, Bahija, and then I will close.
I'm gonna pick one word, persist. To the younger me, but to all of you, at any part of your journey, find a community that will support you. The journey is not easy. Persist. It's much harder for younger women, women of color, immigrant, all the intersectionality aspect is much harder. So persist and find a community that's going to support you.
Wonderful. Communities can start on places like this. Vibhuti, your sentence.
I will say, you got this. I think that you are exactly where you need to be. There are so many who have paved the way for you. And while I think the world loves to hone in on the struggles a lot of people have had, I also like to remind ourselves of the persistence and the bravery and the courage and the valor that we've had leading up to here. So we are standing to make sure the people who have sacrificed and done stuff before us have paved the way, we are going to carry that forward. And you got this. You're exactly where you need to be.
Wonderful. I think so. Standing on the shoulders of giants, as it were. Bahija, your sentence.
Thank you. I'm going to steal part of my sentence from words from Maya Angelou and then end with my bit. So let nothing dim the light that shines from within you, and refuse to accept anyone else's definition of your life. Boldly define yourself.
Goodness me. You do make it a tough act to follow, colleagues, I have to say. What a privilege it has been to chair this, and the time ran through our fingers like water. This is a massive issue. And I think what we've got is the head part, which is the facts on the table and the lived experiences. And then we've got the heart part, which is that we mustn't give up. Tenaciously we will go. My advice to myself would be, don't be so hard on yourself and take a chance, and both things will probably end up being okay in the long run. And as Rupa said, and Vibhuti and Bahija, if you can make some friends along the way, my goodness me, they can be the wings, the wind beneath your wings, I have to say. Colleagues, that's been great. We are 2 minutes over, and the commitments from FIP are to align the Women in Global Health agenda with ours. You have Vibhuti, Bahija, and me behind you, Rupa. We are absolutely standing shoulder to shoulder. Data engagement with our health ministers. We need to create some plans for advocacy around all of this so that we are knowledgeable, informed, and equipped. We will align our work with the ILO's 5R framework, and we will continue this conversation in a CEO interview, ISO. I think this has to be the next one. And hopefully that will be a springboard for other women in global health and other women in pharmaceutical care, pharmacy, across all sectors on this wonderful International Women's Day. Thank you for joining me. Thank you to my amazing team. And thank you for everyone in the back room as well as the screen. Take care, everyone, and have a great day.
Thank you.
Thank you.
Thank you very much.